Good morning, Med Center. Welcome to our town hall meeting, Wednesday edition. I am very happy to announce a very beautiful billboard has been put up that shows some of our amazing staff and the great work that LAC+USC Medical Center does. You can see the pictures here. And our trivia question for today is one, we have multiple sort of challenges. One is, who are the employees that are featured in the billboard? Please send us their names. And then the first two people to take selfies with the billboard in the background will receive a $20 gift card to our CARES coffee shop. So when you take that selfie, please post it on Instagram and tag us. And the first two people to do that will receive the prize. Happy 4th of July weekend. So Friday edition we will not have. And actually on an ongoing basis, we will have the town hall meeting once a week on Wednesdays going forward. It looks like coronavirus isn't going away, but we're happy to continue this on a weekly basis. We will also use this forum to do other informational sessions and meetings, such as our admin briefings, on all staff meetings that may not focus directly on coronavirus, but will be a vehicle so that we can communicate and pass on information. Okay. Billboard. Just going back to the billboard. The billboard was put up without use of any county funds. I actually want to thank Outfront Media. Outfront Media is a company that owns the majority of billboards in Southern California, and they happen to be right across the street on Marengo and Mission. And we did a tour there a few months ago, and they were kind enough to offer us a free billboard, and so therefore you see that. I also want to thank Sandoval Media, who helped us design and take the photography for this billboard, and the LAC+USC Medical Center Foundation, who helped sponsor this billboard. So thank you all. Dr. Spellberg.
Good morning. Hard to be soothy these days, I guess, because coronavirus is increasing. I guess my soothiness thought for the week is that while clearly coronavirus is increasing in LA County and at our hospital in terms of number of new positives, the overall census in our hospital has not increased. We've been fairly stable at around 80, hovering between 75 and 85 on any given day, positive COVID patients in our hospital. And that's been true now for multiple weeks, 3 to 4 weeks. We have not broken our record of 91 that was achieved about 3 to 4 weeks ago. So our discharge rate is tending to match our incoming rate. Now, in the last couple days, we've seen more in the ICU, but again, these are often patients who are coming into the ICU for medical problems other than COVID and are also COVID positive, or they are coming in for COVID, but they're not necessarily on a ventilator. They're on a high-flow nasal cannula. So this is allowing us to keep our bed turnover faster, and that's why, even though we're seeing at least 50% more, if not twice as much, new COVID positive tests, our census has not continued to increase. It has stabilized for the last few weeks. We, as we've often said, cannot predict the future and hope that our ability to match incoming with outgoing will continue to be the same. But I think our staff has adapted remarkably well. We do need to continue to try to optimize how we provide care, and that might mean challenging some long-standing dogmas. So for example, we are actively exploring whether we can care for people on high-flow nasal cannula on the wards, because we have lots of open ward beds. And so these kinds of changes hopefully will allow us to keep a pace with the incoming COVID positives to the hospital. And with that, Dr. Holtom.
Well, thank you very much and good morning. 3 thoughts for the long weekend and then 1 comment about the hospital. For the long weekend, as people are out and about, we need to continue to follow public health guidelines, which would include wash your hands. I always have to say wash your hands, don't I? Wash your hands or use hand sanitizer all the time. Wear a mask when you're out with people and maintain distancing as possible and appropriate when you're out. People need to be cautious. In the hospital, of course, there are several things that we must do. We must wash our hands with contact with patients. We must wear masks when we're within the hospital building. And as possible, we should maintain distancing. We had a visit from a CDPH surveyor yesterday for a reason that she found had a complaint that had no merit, and so that was fine. Unfortunately, as she was walking through the hospital to get to the room where she was going to review the chart and to leave, she noted that there were a significant number of employees, people wearing badges, who were walking through the hospital with no mask on. And she asked about that because it is a policy that we are supposed to be wearing masks. Secondly, at nursing stations and in patient care areas, she found people wearing masks like this or like this. That is not helpful. We are supposed to wear masks in the hospital and in all patient care areas and with all patient contacts. So please continue to maintain what you know should be done. This is protection both for patients and for you and for the other staff.
Thank you, Dr. Holtom. It is an expectation of our supervisors and managers to be kind and remind people that they need to wear masks. As Dr. Spellberg mentioned, coronavirus is raging in LA County. And so the likelihood of infections is going up. So please, please, please follow the expected practice of wearing masks here at the medical center. With that, we'll get to the questions. Dr. Spellberg and Holtom, can you please explain this graph in layman's terms? Thank you.
I guess the first point I'll make is I don't put a lot of stock in modeling. Modeling is subject to human input based on a disease that we still know very little about. And changes to the model are undoubtedly driven by things that we do in society that cannot be predicted in the model. So the first thing I would say is I'm not sure that it's helpful to actually look at these models. I personally don't find them helpful at all. If you want to understand what that graph that is on the screen is suggesting, it's that coronavirus cases are going up. And again, I don't think I needed a model to know that, because public health releases a daily list of the number of new cases. And we're now getting 27, 28, 2,900 new positive cases per day in LA County. And a couple weeks ago, that number was 1,400, 1,500 new cases per day. So the model takes the demonstrated recent rise in new cases and then just projects it forward. And again, I don't find that very helpful. It certainly does show you that if nothing changes and if the increases continued at the current pace, things would be very, 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 very bad. And no one would dispute that. But the question is, will that pace of increase continue? And will we as a society take steps to intervene? And the model simply cannot incorporate those factors.
So aren't you worried about ICU capacity across the county, including ourselves?
But I don't, yes,
Yeah.
But I don't need a model to tell me that. That's obvious,
Okay.
right? We've been worried about ICU capacity since the thing began. I don't need a model to tell me that.
I think the point is the graph is a visual way that someone says, in that person's guess, if all sorts of things happen, given the equation that they created, that's how bad it could be. And I think the answer is yes, but as Dr. Spellberg said, whether or not you have the graph, the answer is we, as several other areas around the country, are now running with a much higher caseload and a thinner margin, and it is possible that if things continue as they are, we are going to have a great strain on the intensive care system here.
Okay. If census of COVID is in decline, not sure that's true, and community spread is getting worse by the numbers, should we continue to limit non-essential visits in outpatient despite opening expected practices and recommendations?
So census of COVID is not in decline. Census of COVID, as I mentioned at the beginning, is stable.
Census meaning number of people in the hospital, not in the community.
That is correct. And the community case numbers are going up, and frankly, numbers of new positives in the ER, as we mentioned, are going up. It's that we have thus far been able to match the increase in incoming traffic with the increase in outgoing discharges. And that's in part because the average severity of these cases is less, so they stay, and the average length of stay is shorter. They stay less time, so we can match the incoming to the outgoing. That has been the case thus far. This is an example of why modeling is highly problematic. I would never have predicted that in April. Who knew that we would be seeing more cases but fewer people on ventilators? It's not possible to predict that stuff. We don't understand this virus. We don't understand the disease. We don't understand the factors that drive cases and severity. I don't know how you can possibly accurately model that. That's what my concern with modeling is. What we have are numbers that are real, and we react in as close as real time as we can to those numbers, projecting forward the best we can to come up with plans to keep us as best we can out of trouble.
Okay. How are we as a facility fighting systemic racism to help properly and compassionately serve patients who are being disproportionately affected by COVID-19? Thank you for this question. I think the issue of systemic racism speaks to kind of the infrastructures of a system, of an organization. And I am very proud to be part of Department of Health Services and LAC+USC that really commits itself to delivering world-class care to everyone. And I think, as an organization, I think that's our mission. That's what we've always done, and I think that's our contribution to that. Now, having said that, there are many things within our hospital, within Department of Health Services that contribute to systemic racism. And I can tell you that the solutions are not easy because these are systems that have been put in place over decades and decades and decades. The exciting thing is that the Department of Health Services is starting conversations about what that looks like. What does that look like in DHS? How are we contributing to systemic racism, and what kinds of changes should we be making? So there is ongoing conversations at the highest levels of DHS to try to tackle this and to come up with some recommendations, and we'd be happy to share those recommendations as they come up. Any other thoughts on that? Okay, new CDC guidelines now include new symptoms. Dr. Spellberg, what are they? Could you have COVID without a fever? Is this something to be concerned about?
So I'm going to avoid commenting on CDC.
Okay.
And just state, you could always have had COVID without a fever. That's not new. There's lots of symptoms we know you can have with COVID. You don't have to have a fever to have COVID. In fact, frankly, we know you can have no symptoms and have COVID. So I did not look at the CDC symptom list It's a viral syndrome that affects the lungs disproportionately. And that's what we need to keep in mind. We've had people come in with predominantly diarrhea that were COVID related. So I'm not sure that having a list of symptoms is something that is particularly meaningful to inform my clinical decision making. I don't know if you would like to expand on that.
I think that the expanded list of symptoms lists symptoms that many, perhaps most people, have already included or known, at least in medicine. It does expand. The list of symptoms previously was based on the knowledge months ago, which in COVID time is an eternity. And so it didn't really reflect what we all see. People come in with loss of taste and loss of smell without fever as their only symptom on presentation. So there are many things that we're learning about the virus, and CDC is going to continue to update lists like that. The utility probably is that people can go to a single place and see easily some, but certainly not exhaustive list of symptoms that people may present with.
What's happening with Santa Claus wipes? Why is LAC+USC running low?
I have no idea. Are we running low?
Yes.
Okay.
We are? Mm-hmm. So looking at my little chart here, it says that we have 8,856 little tubs of Sani wipes, which sounds pretty good, but we probably burn through
a lot.
Yeah,
and we are having spot shortages, and we understand that. What's happening, actually, it's what's happening with everything in the world. As demand has risen, companies are having spot shortages in lots and lots of things. And so we continue to look at other products. There are specific products that come from specific manufacturers. We look for alternate products, alternate ways of providing the same thing. But we can anticipate as this goes on, we will continue to see spot shortages in different areas.
So I would just go back to a point that Mr. Orozco has made repeatedly. If we have 8,800 Sani wipe containers in our warehouse, there is no part of this hospital that should be experiencing a lack of Sani wipes. Our experience has been when people in the hospital have felt as though there are shortages, it is because there has been a communication gap between the management or supervisor of that area and the management and supervisor of the warehouse. Those issues need to be escalated in real time up the chain of command so we can close the communication gap and deliver the product where it's needed.
Okay, well said. A family member has, Please review current procedure when discharging COVID positive patients. Do we escort patients to Clinic Tower Pharmacy to pick up their meds?
My understanding, and I would need to confirm this honestly, is that the medications are supposed to be delivered up to the ward for the patient so that the patient does not have to go to the discharge pharmacy if they're COVID positive.
That is in general true.
Okay. So, I mean, we can raise this issue with nursing leadership to ask if there needs to be sort of a re-in-servicing, but that is our understanding of what is supposed to happen.
And if there are issues with the pharmacy, we should talk with pharmacy as well to make sure we can achieve that.
Yeah.
My family member has mild, mostly flu-like symptoms for about a week now, but is improving. Is it safe to say they are out of the woods?
Well, I guess there's a bunch of ways to interpret that question. I guess one question could be, you're presuming they had COVID and now they're going to be fine because they're getting better, or are you saying, is it safe to say they didn't have COVID? The fact is that viruses cause very similar symptoms, and you cannot distinguish mild virus A from mild virus B, including COVID-19. I would say that if someone is better, then it's unlikely they will end up suffering serious harm. And we do need, if it's COVID-19, we do need to remember that the data that continue to emerge do suggest we've been, as Dr. Holtham and I thought was likely initially, we've been undercounting COVID cases by a factor of at least 10, if not 20, which means when people quote you these very scary death rates of 2, 3, 4%, they are likely overstated by 10 to 20 fold. So Remember, most people don't get terribly sick from COVID-19, but we have an intense selection bias because we only see the ones that have gotten sick from it. We don't see the ones that don't. And so I would say if somebody ends up with a mild viral syndrome and a week later they're better and they're fine, yes, they are probably out of the woods in terms of danger from the virus, but it doesn't tell you whether it was COVID-19 or not. And I don't know if you'd like
Let me just say, everything you said is absolutely correct. And as long as we say probably they're going to do fine, that's absolutely true. There's no question that we see people every day who come into our ED who got sick with a flu-like illness 2 weeks ago, and we're kind of doing okay, and then over the last week or so, they've gotten progressive shortness of breath, and they end up here and may require high-flow oxygen. So there's no question that people can have worse courses even later in the time, but that's unusual, and as Dr. Spellberg said, we have a terrible selection bias because, I don't know, I see that every day, but on the other hand, that's not what's happening in the community for the most
Paul,
part.
I mean, I'm very curious as to your experience. On my review, we don't see a lot of biphasic illness where they're sick, they're much better, and they get sick again. What we see is they're a little sick, they're a little sicker, they're sick. We tend to see a sort of a progressive picture.
That's mostly true. Some people say they weren't doing too badly, and then over the last few days they've gotten worse, and this is now 10 to 12 days out.
Yep.
So my family member, should I stay away from them still? Because are they infectious?
Depends what your family member is doing during the day while you're here.
So
well,
I think I think what we'd say is that you want to, if there's a possibility that it's COVID-19, you want to self-isolate for 7 to 10 days after symptom onset, presuming you never get sick enough to go to the hospital. Is that
okay?
what you
Agreed.
said?
All right. Will this facility consider installing ultraviolet light systems in the elevators? What does infection control say about ultraviolet light systems?
Well, could we consider it? Yes. It's expensive. The likelihood it would help a great deal. It certainly isn't going to make it that we can pack the elevators again, because whether or not you have an ultraviolet light there, which would be just for the air, we don't actually irradiate the people per se. You're supposed to still limit the number of people in the elevators so that you can maintain some sort of adequate distancing. So I don't think it would help our major problem, which is less people are going to be able to ride the elevators, more people need to do aerobic exercise on the stairs.
Yeah, you cannot have UV lights on in a space where there are people. UV lights are bad for people. UV lights are bad for microbes, but they're also bad for people. So you can only have them on when there's no people in the space.
It's kind of like bug spray and spider spray. It's bad for them, but also bad for us.
So as somebody who is in the antibiotic resistance space, I was asked, it's really hard to find things that kill bacteria and viruses. It's not hard at all to find things that kill bacteria. Fire kills viruses and bacteria really well. It just, you can't put patients on fire. You would totally sterilize them, but it would be a Pyrrhic victory. Similarly, UV light. You can't be shining UV light all over people. Yeah.
Okay. So what should we be asking patients who are scheduled for an outpatient essential appointment? Can you please review the procedure?
I'm not sure I fully understand. Do you have thoughts about this?
I believe what they're asking is when the patient gets a phone call before the outpatient appointment, what should we be asking them? Or maybe what do we ask them at the door before they come in? Would that be what you understand it as a question? Obviously, if they're there in front of you, there are many things you would ask them. But I assume these are the screening questions before they can get in for this kind of an appointment.
Have you had a fever?
So there actually is a script
Yeah.
that people are using with major questions such as, have you have a fever, do you have a cough, and so forth, that is written out for people to use. And if someone says yes, then we try and figure out a way to provide them essential medical care, but not in a face-to-face, or at least in a safe face-to-face environment. The same as there is a script for the people who are at the doors, that they stop each person and ask them the script, have you had any of these things? And if the answer is yes, then they're not able to enter until they have more evaluation.
I saw an ad on Facebook for this UV light that cleans your cell phone. Is that cool, or does that work?
So UV light does inactivate the virus. I think that's pretty well established. UV light does not actually clean, though. And that's a big important distinction, because one of the ways that things like UV light are made to fail or don't work is if there is dust or dirt and the virus is below the dust or dirt and the UV light just bounces off the dust or dirt. So anytime you're going to apply any cleaning product, whether it's a liquid disinfectant, whether it's UV light, whether it's one of these misting devices, you have to clean away visible soiling first. And then if you've cleaned away visible soiling and you are not around where the UV light is, you could use UV light to disinfect a surface.
Correct. Cleaning is still the base of everything. There are a lot of magic things that people have put out to clean rooms, even before COVID. But the problem is you still have to clean off the surface, because if you leave contamination, dirt, dust, blood on a surface, then none of these things are actually going to kill the microbes that are there.
On the news, it was recently said that llamas contain antibodies that might be helpful. Is there any
Dr.
truth
Spelberg,
to
can
that?
you talk about
Yes, I
llamas?
can actually.
Thank you.
Believe it or not. The llama is an amazingly evolved animal. Llama antibodies are fascinating. They are much smaller than human antibodies. And so there's a lot of interest in the immunology community in taking human antibodies to treat diseases, but actually creating a llama equivalent, because they're smaller and can get into little nooks and crannies that human antibodies are too big to get into. That is absolutely true. I am not aware of antibodies being too big for coronavirus. So for example, in my laboratory, we look at bacteria, and the bacteria have an outer cover that has little pores in it. Llama antibodies may be able to get in those pores directly to the bacteria, whereas human antibodies are too big. I don't think there's an equivalent for the coronavirus. So I'm not aware of any specific advantage of llama antibodies for coronavirus, but generally speaking, there is a lot of interest in immunology with respect to llama antibodies.
Way to go, llamas. With that, I want to wish everyone a wonderful weekend. Please enjoy your loved ones and family safely, and we'll see you next week.